In the spirit of reconciliation, we acknowledge the Gadigal people upon whose land we meet today and the traditional owners of country throughout Australia and their connections to land, sea and community. We pay our respect to their elders, past and present, and extend that respect to all Aboriginal and Torres Strait Islander peoples today. And from wherever you are in this wonderful country of ours, please feel free to pay your respects to elders past and present from the land in which you are participating. Good afternoon. My name is Adrian Kazenza. I'm the Chair of the Australian Ethical Health Alliance and also the Chief Executive Officer of the Australian Orthopaedic Association. Welcome to this 2021 Symposium, The Ethics of COVID Vaccination from Discovery to Distribution. For housekeeping, attendees, you're allowed to chat with panelists only. We encourage you, please, to submit your questions through the Q&A feature. Only those questions that receive a response will be seen by the audience. The raise hand function is a default. It does not function. So if you need, it's been disarmed for this seminar. A quick background to the Alliance. What is the Australian Consensus Framework for Ethical Collaboration in the Healthcare Sector? It's a consensus of shared values and ethical principles that form the basis of collaboration and interaction among organisations in the Australian healthcare sector. The signatories have agreed to a simple yet effective set of ethical principles, 5 substantive principles and 9 procedural principles. There are 75 member organisations representing the Australian population and over 350,000 health professionals, employees and trainees covering all sectors within health and with the full endorsement of all state and territory jurisdictions and the federal government. The framework aims to promote collaboration and interaction, to encourage better dialogue, trust and respect, to promote public confidence and trust. The Alliance was formed in 2019 as the leading body to guide the implementation of the Australian Consensus Framework, and its aims are to facilitate ethical behaviour, provide general guidance, encourage and monitor the activities related to the principles outlined in the Australian Consensus Framework. It's not only a basis for how healthcare sector should function during times of crisis, but also a roadmap for how stakeholders can cooperate in the future. So with that very small introduction, I would like to warmly welcome our symposium moderator, Dr. Michelle Ananda-Rajah, who is an infectious disease specialist and general physician at Alfred Health and an advocate for doctors throughout the COVID pandemic. And I would like to hand over and also thank in advance all our panelists who are going to be part of this extraordinarily topical subject matter today. So over to you, Michelle.
Thanks, Adrian. Welcome, everyone. Really delighted to be here, and thank you to the organisers for having me moderate this session, which is timely and highly relevant. So I'm going to give you a bit of a overview of the global landscape and then talk about some of the key ethical issues that are used to inform individualized care at the patient level. So I am a practicing doctor. I see patients every day, and this is, highly relevant to how we manage people. I also teach and train a lot of other doctors as well. So we might just move to the next slide, please. These are my disclosures. I do hold some CSL shares, not very many. Next, please. Thank you. Okay. So this is a global snapshot. So you can see that on the right there, we've got 184 vaccines, lots of vaccines in the pipeline. And we need that, over 7 billion of us on this planet. And 8 now have come to fruition to market. But, it's been unprecedented in its pace, but it has followed the highest regulatory standards with respect to safety. There are 4 basic technologies: the viral vector vaccines, such as AstraZeneca, Johnson & Johnson, the mRNA vaccines, Pfizer, Moderna, for example, and then there are the inactivated protein subunit vaccine, Novavax, which we haven't yet received. Vaccines have received either full or emergency approval in some countries, and in Australia, at least, the Pfizer and AstraZeneca have been provisionally approved by the TGA. As you know, the UQ vaccine and the Merck vaccine did not proceed. past phase 1. So next slide, please. And these are the candidate vaccines, just a schematic of them. We've got the viral vector vaccine, AstraZeneca there, in the middle, Moderna and Pfizer, which has the genetic blueprint for the spike protein inside a lipid nanoparticle, or a fatty bubble, if you like. And then on the right there is a completely different design, a more traditional design, which has been in use for decades now, called a protein subunit vaccine. And this is where the spike proteins in red have been cultivated in the cells of moths, actually, and then attached to a nanoparticle, and alongside it, boosted by what is called an adjuvant. And the adjuvant in this case has been derived from the bark of a soapbark tree, a Chilean soapbark tree, which is just fascinating. So I guess the AstraZeneca vaccine and the Pfizer Moderna vaccines, these would be a type of gene therapy, if you like, and these are relatively new vaccines. The mRNA vaccines are the first vaccines that have entered into widespread use, been licensed for use, but they are not an overnight success, all right? This is 30 years in the making of R&D before this, the breakthrough occurred. AstraZeneca is a viral vector vaccine. There is only one other viral vector vaccine that has ever been approved for use, and that is the Johnson & Johnson Ebola vaccine that was approved in July of last year by the European Medicines Agency. So they're both relatively new. Okay, next slide, please. This is from the OECD, and it just nicely puts together, all the bits and pieces. There are lots and lots of moving parts here in getting vaccines from the lab into the arms of people. And I just wanted to highlight that it's not just about science and logistics and supply chains, but this area in yellow, which really comes down to social sciences, how we communicate and how we build trust and not erode trust or undermine it in the public. And I've got here two quotes, one from the OECD and one from the WHO, and they both are in alignment, basically calling for transparency in order to build trust and effective communication. So communication must be evidence-based, and it must be transparent in order to build trust with people. And this is something that I'm obviously all doctors are very invested in this, because you are worth nothing as a doctor if you lose trust with your patients. Next slide, thanks. So how are we doing? Next, please. So this is, I took this yesterday. This is a snapshot of, you're all familiar with this graph, and it looks at people who are fully vaccinated. And this is relevant. I think this is the most relevant metric, actually, because for the Delta variant, you all know that you need 2 shots in order to really deliver that knockout blow. And Australia, unfortunately, is really the laggard here, right at the bottom of the OECD, which is a matrix of rich countries. Next slide, thanks. From a global perspective, I just wanted to highlight that it's not just about us in the OECD. There's a whole planet here, and we are really lagging behind in low-income countries who've had less than 10 million doses. So, we need to not only get ourselves sorted and vaccinated, but then push vaccines out to the rest of the world. Otherwise, this pandemic will never end. Keep going. This is just a slide looking at some AEST data, recently a survey that was done looking at vaccine intent. I think we should be using language like intent rather than hesitancy, because hesitancy tends to just drive more hesitancy, and it can be a bit of a misrepresentation of what's actually going on. So over here, we had about 25% at the time this was taken, which was around June. 25% of people were not sure as to whether they would get a vaccine, either disagreed strongly or sitting on the fence. But actually there's more to it than that. I just wanted to break this down. So 55% actually were happy to go and see their GP. So not everyone is sold on mass vaccination hubs. Some people really do like going to see their GP to get their jabs. In fact, I went to see my GP to get my flu shot. I didn't take it at hospital. And then with respect to actual, what's going on with not actually receiving a COVID vaccination, only about 15% wanted a different vaccine. With respect to everyone else, up to 19 or 20%, nearly 1 in 5, just couldn't get access to the vaccine or weren't sure how to make an appointment, weren't sure if they were eligible. So there are lots of other factors that play into why people don't necessarily get vaccinated. It's not just about wanting another vaccine. And I think actually with respect to what's going on in Sydney, I get a sense that, hesitancy is actually evaporating just because of the problems with the outbreak. Next slide, thanks. So the ATAGI guidance has chopped and changed, and I've just got some, milestones here. On the 8th of April, it was preferred for people less than 50, and that was in response to a 44-year-old healthcare worker who developed this clotting problem, TTS. June 17, it changed again to being preferred for people less than 60, and that was in response to a spate of TTS cases in young people, particularly in the 50 to 60-year-olds. We don't have a lot of detail around that except for the core numbers, but there was clearly, a concern amongst ATAGI that morbidity or suffering was quite significant in this group. On July 13th, the ATAGI then revised this again and really just nuanced it up a bit and said that AstraZeneca could be considered in younger people less than 60 in the context of an outbreak, particularly if access to Pfizer was constrained. And that was really, I guess, in response to the Prime Minister's comments on the June 28th, which were sort of similar. So he foreshadowed it and this change occurred. And they also shortened the dosing interval from 12 weeks to 4 to 8 weeks. Next slide, thanks. So risk benefit, it's all about risk benefit. So all these numbers in the end get distilled down in the doctor's consulting room between the patient and the doctor. So if we move to the next slide. So risk has actually been misreported, I think, in a lot of sectors. Risk is actually a combination of likelihood and impact or consequence. So we've heard a lot about likelihood, and likelihood is widely reported, infinitesimally small numbers, percentages, often incorrect, I might add. But impact is what is forgotten, and impact ranges from negligible to extreme. And so, you may have a rare complication such as TTS, but the consequences for someone might be either moderate, major, or extreme, and it would vary depending on, for example, age. So, this is the important thing to take home here, that risk actually might be sitting in the medium level for most people. And hence early on when we, were cruising along with COVID-0, this is probably why a lot of people were backing off, because their own perception, they had taken this into account without actually making it explicit. I think this is very important to actually take in mind, because this is the kind of conversation we have with patients. Next slide, thank you. So patient autonomy and choice is important, and it's certainly been acknowledged by ATAGI, who also say that, they realize that it's very difficult for people to assess personal risk. And I think that's absolutely true. Next slide. It's difficult for doctors as well. The Australian Charter of Healthcare Rights is worth looking at. It does talk about having your beliefs and choices recognized and respected. It's been difficult, I think, to actually operationalize this, just given the fact that we have so much constraints on our supply. So how do we actually support patient choice and autonomy when we simply don't have enough vaccine to go around? Next slide, thank you. This was a comment that came up onto my Twitter feed from someone. I think it was quite, quite insightful, actually. For the person that gets the serious deadly side effect from the AstraZeneca vaccine, the risk would have been 100% for that side effect. Stats are just numbers. Behind them sit actual people. So this is, again, from an ethical point of view, the tension between the population, what's good for the population, and what's good for the individual. And we have to somehow navigate people through that tension. It's become very polarizing, unfortunately, to even talk about any side effects or problems with vaccines, any vaccines, and you get attacked for doing this publicly, you get trolled. And I think that this is a really, really, this is inappropriate, and we need to take the heat out of this so that we can have open and respectful conversations with people. Next slide, please. So I've just got here, I'm not going to go through all of this, but I've given you the data. I've looked at this yesterday. We've had, for example, TTS is the #1 thing that people are concerned about. We've had basically 83 cases in 5.4 million vaccinations. I'm not sure how many were second doses. That approximates a range of about 1 in 65,000, but it's age dependent. One case we've had after a second dose, and the overall rate is very low, 1.7 per 1 million. So, everyone who's had one dose of AstraZeneca should be strongly encouraged to have the second dose. Of these 83 cases, 35% have occurred in young people, less than 50. There seems to be a slight preponderance for women. median onset's about 12 days. 36% needed ICU, so not a trivial disease, and we have had 3 deaths of people with confirmed. I think there was one case also of death in a patient who had probable. The incidence rate in young people is really difficult to determine. Based on data from Norway, which suspended the AstraZeneca vaccine when they started seeing the signal, it was around, I think it's going to be somewhere in the order of 1 in 20 to 1 in 30,000. But you know, it's really difficult. We would be one of the few OECD countries now that is offering AstraZeneca to young people as young as 18. In fact, the UK on the 4th of May elevated it the age threshold to 40. So if you're 40 years or below, you will be offered either Pfizer or Moderna in the UK. The UK yellow card reporting is well worth looking at, and this is released like the TGA report, which is excellent actually, every week. And in the UK, they've reported 405 cases, about 15 per million, 1 in 67,000. So it seems to be settling at that rate overall, but again, there's wide variation depending on age. 20 per million if you're less than 50, 11 per million if you're 50 and over. Again, similar slight preponderance of women. Mortality is higher, but it has remained stable in the UK. I have been looking at this, and 2/3 of their cases have occurred in younger people less than 60, and hence they have that age cutoff. Next slide, please. There have been other side effects as well with both AstraZeneca and Pfizer. Myocarditis, pericarditis, which is a type of heart inflammation, very, very rare. And for all intents and purposes, appears to be self-limiting, benign, and gets better, basically, in about 95% of people. There have been other things that are being investigated now. This was highlighted in the TGA report. Guillain-Barré, capillary leak syndrome, ITP, very rare as well. Next slide, thank you. So, you know, I've talked about the risks. So these are the sorts of discussions that you would have with the patient sitting in front of you in a doctor's surgery. You have to go through this because this is what informed consent is all about. But the benefits then are both direct to the individual, such as preventing death or hospitalization. And then there are obviously indirect benefits to the rest of the community or to their inner circle, their family, etc., in reducing transmission. So I've got here, and I won't go through all of this, but basically this is the mortality rate based on Australian data for each and every age band. And you can see that, you know, it's significantly different if you're over the age of 60 compared to if you're a young 18-year-old. So a 20-year-old, for example, would have a mortality rate of COVID of 0.1%, which is 0.01%. That is a tiny, tiny number. In the end, what we do in the discussion is we take into account people's health, social and economic circumstances to inform that decision making. So for example, is a young person obese, because that will increase their risk of mortality? What are their social circumstances? Do they live in a share house or a multi-generational house, or do they live alone? Economically, can this person work remotely, for example, or are they an essential worker in a public-facing role? So these are the kinds of factors that will determine whether, you know, you're offered a doctor will you know, veer towards offering a vaccine or counselling against one, for example. Next slide, please. So just to conclude, choice and autonomy are important, but right now constrained by our supply. And choice, don't forget, is very much informed by lived experience and personal trauma. It's not just about risk assessments, okay? It's a very personal choice. And really, in the end, it's between the doctor and the patient and no one else. Transparency of data and decision-making is absolutely essential to build trust. You know, we have this tension between utilitarianism, the greater good argument versus the individual. And finally, you know, to end this pandemic, we need equitable access to effective vaccines against variants for absolutely everyone. Okay, I will stop there and introduce our first speaker. So this should hopefully get all your creative juices thinking. We strongly encourage questions. We'd like you to put your questions up in the Q&A, and as we're going, the panelists will be answering them as best as possible. So, you know, lots of questions are welcome. So I've got with me Professor Bill Bowtell. Bill is an expert in public policy. He is one of Australia's foremost health policy strategists. He was a chief of staff to Dr. Neil Blewett in the Labor government, and also a senior advisor to Paul Keating. And Bill has really served many roles and capacities and led work around the HIV during the HIV pandemic, and has done a lot of work in the region around tuberculosis and malaria. So I'll hand over to you. Thank you, Bill.
Thanks, Michelle. And Thank you, Adrian, Alyssa, and everybody for putting the seminar together, and for everybody who's joined. It's a great pleasure to be here. As Michelle said, my career, just by the luck of the draw, I think, has been bookended by two great pandemics. The HIV/AIDS pandemic that erupted in the mid-1980s, and now, of course, COVID. And the lessons I learned then, watching and participating in the response to HIV/AIDS back in the 80s in Australia and globally, are lessons that apply now. It's very important, it seems to me, that we understand and learn the lessons of the HIV/AIDS response in Australia and around the world, and that should have been applied to the COVID response. And I think it won't come as any surprise to you to know that my belief about why the Australian response was so good in the end was it was intimately associated with morality and ethical decisions made by the government and the parliament of the day. That is, the morality and ethics that underpinned our response was inseparable from the quality of the response. And I think in the last year or so with COVID, we can see in many countries in the world where the moral and ethical underpinnings evaporated, and the response was accordingly much worse than it ought to have been, much avoidable suffering and death. So what happened briefly in the HIV response in Australia was that when this unexpected emergency erupted in mid-1980s, early 80s, the Australian government had a very big decision to make. How would the response be based? On what would it be based? Would it be based on science and evidence, or would it be based on short-term political and other considerations of the sort that we saw erupt in the United States? In short, the Australian government, after consultation with scientists, clinicians, the community throughout the parliament, decided that the Australian response would be based on science and evidence, and that the political imperative was to persuade the Australian people to respond to a very serious and dangerous situation of this virus, a virus for which we had no vaccine or cure or even treatment for many years, to understand the need for behavioural change and for very complicated and complex changes to be made to particularly in at-risk communities, to make sure that they were not overly affected by the spread of HIV and AIDS. That worked extremely well. And at the core of that response, if I can say, as we've seen on the screen here, the Australian government of the day decided that we would base the response on trust. Trust in evidence, science, basis for action, trust that the education could bring about sustained change in at-risk behaviours, trust that high-risk groups would educate their peers, trust that the government would not resort to punitive measures, and trust that the governments would tell the truth about HIV and AIDS, both what we knew about it and what we didn't know about it. All gained at gaining time. Time for science to investigate the causes and nature of the spread of HIV, to come up with treatments, hopefully, but never came up with vaccines, and hopefully, but never really came up with a cure. The next slide, please. That required political leadership and imagination. It required a definition and defence of the public and the national interest. It required good communications, public relations, issues management. It required a great deal of discussion and talk about planning, but when the decisions were made, swift implementation. It required working with medical and clinical establishments, but working around silos and defensive interests. A belief that prevention could work, that if people were properly informed, they would take the necessary steps to change behaviour, and the action would be based on reason, but would be informed by an ethical and moral framework. Next slide, please. Of course, the overall intention of what was done in the HIV days was to minimise the risk for the general population, There was a great deal of investment in research and epidemiological, clinical and social aspects of the HIV response. There was respect for human rights, legislative change to ensure anti-discrimination, the idea that there'd be long-term over short-term thinking, and very importantly at the core of it was what we called the partnership, which was the partnership between the governments, the scientists and the clinicians who are closest to the problem and researching the problem, but very importantly, the at-risk communities. That is the people who are most impacted by the spread of HIV, but the general community, the broad general community. And to encourage this partnership, there had to be openness, honesty, transparency. All of this led to an increase in trust. And it was this increase in trust that allowed the most remarkable range of extremely radical and bold measures to be undertaken in Australia. A very frank education about sexual behaviours, the introduction of needle and syringe exchanges, and a sustained communication campaign to change risky behaviours, to educate each cohort that was coming through, and to gain the approval of the Australian population, the political parties, to keep funding and encouraging this sustained behaviour change over 40 years. And over 40 years, the results have been remarkable. Because of that investment based on trust and openness, we've had a tremendous reduction in new HIV caseload. As treatments became more and more available and were distributed, they had a tremendous effect in reducing the impact of HIV and AIDS in this country. That was not the case in much of the rest of the world. There was a merging, if you like, of politics and science. Too much politics and not enough science. And one of the great things I think that happened in Australia that we should have learned from with COVID was that science was separate from politics. In those days in Australia, the scientists were convened under very eminent specialists, clinicians, researchers. They gave their scientific advice completely separately, openly to the government. The government tended to learn what they'd said when the fax machine conveyed their press releases. But it was up to the government then to impose a moral and ethical framework on the decisions that were made on the basis of openness, discussion, the widest possible input from the community, understanding that if we got it right, the rewards would be very good. But if we went down the path that so many other countries went down of this collision between science and politics, we would come up with very bad results. So coming forward to COVID, I think that those countries in the world that gave an expression to a moral and ethical basis for their response at the beginning of last year have done very well. After a rocky start in Australia, I think the great decisions that were made in relation to the lockdown really, obviously, as we know, saved lives and illness. And by October last year had basically brought us to a zero COVID state, a state that can't last forever, but a state that gave us time to respond. Unlike in the HIV days when the treatments took 13 years to arrive and we never had vaccines, thanks to the great work and mobilisation of science, we have vaccines. So we gained the time, and now we have to impose a very strong moral and ethical framework on the availability of vaccines, both in Australia and around the world. The first, of course, being that everybody has a right to be vaccinated. Everybody has a right to receive those vaccinations free of charge and unnecessary complication. Those vaccines must be made available on an equitable basis. Very importantly, everybody has a right to information about vaccination. Back in the HIV days, information was imperative. Everybody had a right to know what was going on, the steps they needed to take to protect themselves and their partners. Similarly, in relation to vaccination, everybody has a right to that information. Now, the information is complex, it changes. That makes for difficulties, as we've seen in the last several months. But if the communication, that is their right, is directed at all of the Australian communities in their great diversity and glory, delivered by people in whom they have trust, the information is correct and it's sustained, then of course, without a doubt, the vaccination rates will rise appropriately. We'll be able to address those people who are hesitant, maybe 20 or 30% of the Australian population. And I think over time, with openness and trust and honesty, we can address those people who, for one reason or another, we would define as anti-vaccination. Everybody has a right to that information to be treated equitably and openly. So without trust, without an understanding of the moral and ethical imperatives that must now underpin the vaccination program, we will have a very much less than optimal outcome. We do not want confusion to continue. We want the openness to be there, and remembering now from all the advice that we seem to have that there won't just be one period of vaccination and then there'll be a Freedom Day. There are going to be changes in the regime of vaccination in Australia and around the world that might involve continual tweaking and booster shots and so on. And this will be really a tremendous change in the way in which the Australian government, the public health system, has to deal with the population as the nature of COVID changes, the nature of the vaccination response changes. So this is the beginning of a very long and indefinite struggle, I think, in relation to persuading people about vaccines and vaccination, what it means. And if we build on the trust that we saw work so well in the days of the HIV and AIDS response, if we build on the trust that is at the heart of the public health system in Australia, then we will do very well. Thank you very much.
Thanks, Bill. That was amazing. I do wonder, given our success with HIV, what has gone wrong? I wonder if you can, I mean, it's just, I know you've written a book about this and I've read it actually. It's an excellent book. What would you think would be the take-home messages? What advice would you give our leaders on how to salvage this now?
The one thing that's missing in the COVID response, and I don't for a moment want to undermine our politicians or the scientists who all participated in it, but the community was the missing point. Now, we needed an approach in Australia over the last year and a half where there was openness and honesty. The scientific advice, for good and bad, whether it was right or wrong or whatever, ought to have been published when it was given. It should have been contestable and debatable and reviewable. But what we had in Australia was a desire to keep this within the national security structures of cabinet, as if public health had somehow become secret health. Now, this would have been catastrophic in the days of HIV and AIDS, because science needs to be disseminated. And the basis upon which political decisions are then made needs to be, in a democratic and open community, decided by the representatives of the people with the consent and informed judgment of the people. It cannot be delivered from behind closed doors in press releases by politicians. One of the great decisions we made back in the HIV days with politicians, prime ministers, leaders of the opposition would have no part to play in talking about the science of HIV. So they took a backward step. They funded a lot, but they weren't up front. And there were very good reasons for that, because politicians generally, no matter how good they are only supported by half of the population. So why would you put a politician up front when we should have credible, effective, trustworthy scientists? And then by all means add the politics, add the value judgments. Politics is a way in which we, as a community, put our value judgments and our morality and ethics into the equation and come up with acceptable policy. So I don't believe in secrecy. I don't believe in these things being decided behind closed doors.
Totally with you on that. Thank you, Bill, for those insights. Okay, we might move on now to our lawyers, our legal eagles. So we have with us Alison Choi-Flanagan and Carl Rosenberg, who are both partners and leaders at Hall and Wilcox. Alison has over 25 years of corporate and commercial regulatory experience, specializing in advising clients in the health, aged care, disability, life sciences, and community sectors. And Carl is a partner and the head of employment law, I believe, at Hall and Wilcox. So welcome, thank you both.
Thanks, Michelle. We're just going to go quickly through the slides, but we're happy to make them available.
Don't go too quickly, Alison. Don't go too quickly. It's fine.
So what I'm going to talk about is about from the legal perspective about the COVID-19 vaccine and whether it should be mandatory. So some of the things in terms of from a legal perspective is what the Australian government approach has been in terms of legislation, balancing public health and human rights, safety, efficacy and ethics. Does the government have public health emergency powers to mandate the vaccine? Carl will talk about the employer's position in terms of mandating the vaccine. And can service providers mandate the vaccination, for example, airline companies, and some of the history and cases if I have time. So the government approach has been, first of all, they've said that they're going to say that it's not going to be mandatory for the population to have immunisation, and it will maintain that individuals have the option to choose not to vaccinate. But for certain high-risk industries, the government has considered that very carefully. So on the 28th of June 2021, National Cabinet agreed that the COVID-19 vaccination of residential aged care workers will become mandatory by mid-September 2021. The actual orders have not been all published, so the devil will be in the detail. But what we've seen in various states and territories that they have mandated workers to have flu vaccines where reasonably available, and that's where the exceptions come into place. And I would expect the same in relation to the COVID-19. So say, for example, if a worker is allergic to the vaccine or it's not available, then that would be an exception. And we haven't seen the legislation yet, but we would expect that to occur. So in Australia, we don't have the same sort of civil rights as in the US, but we are a signatory to various treaties. And a number of those treaties expressly protect bodily integrity. And that's what we're talking about informed consent, the right to consent to medical treatment, and that would include the vaccine. And under Article 7 of the International Covenant of Civil Rights and Political Rights, civil and political rights, no one shall be subjected to torture or to cruel, inhumane or degrading treatment or punishment. In particular, no one shall be subjected without his free consent to medical or scientific experimentation. However, when we look at the legislation is about ensuring public health and safety. So when you're looking about that, we're also talking about benefits and human rights, non-malfeasance, so not doing more damage than good, distributive justice, so a fair allocation of scarce resources, which includes the vaccine, procedural justice, consent, and certain conditions and rights we have in relation to what the government has been doing in terms of research and approval of the vaccine through the TGA process, which is a rigorous process. Technically, the Australian government does have certain powers, and you've seen them. The state, commonwealth and state territories have been passing orders and declarations. And so technically they may have the power to mandate vaccines, but only in certain circumstances. When we're talking about COVID-19 vaccine and to be mandatory, we're talking about whether service providers can make vaccination a condition of entry, conditions of service, anti-discrimination legislation, for example, if someone is allergic, an alternative condition. So, for example, when I talked about the government's response in terms of the flu vaccine, how to deal with people who are allergic, and obviously the way to do that would be through stricter quarantine requirements for those particular people. I'm going to finish before Carl starts, but if we go back to history, when we talked about what's happened in the past and the smallpox vaccination, Professor Simon Cole says the mandatory smallpox vaccination legislation in the 19th century England was fraught with difficulty, and after various modifications became arguably effectively unenforceable. So I would agree with the previous speakers. It's about communication and transparency. Thank you. Carl?
Thanks, Alison. I'll just share my screen. Oh, no, wrong one. Thank you, Alison. My journey with COVID-19 commenced obviously when the epidemic started, advising employers in relation to the full gambit of issues from standing down employees in the early days, redundancies, JobKeeper, working from home, and then returning to the office. And that's evolved now because during that time, a vaccine's been developed, and now the key issue for employers has been one of, well, what do we do in the context of this vaccine? And the key ethical and legal issue is, I get asked this all the time: can we mandate the vaccine for our employees? And I think it's also important to consider that in the context of what happens if the employee refuses. From an employee's perspective, they'd like to think that they have the right to choose whether they obtain the vaccine or not. But do they really have the right to choose if the threat of losing their job is hanging over their head? And I think that's a real issue for people in this context. So, and from the employer's perspective, obviously they need to make sure that what they're doing is legal and that they're complying with the law. Otherwise, they face the threat of litigation. But at the end of the day, if they are implementing it and someone refuses, what I'm hearing from my clients, especially in the aged care industry, is that they can't afford to lose these employees. So they're sort of stuck. They're stuck in the middle here. On the one hand, that we might have a public health order indicating that we need to mandate the vaccine, but are we prepared to face the consequences? In terms of mandating the vaccine, a lot will depend on the circumstances. What's applicable in an office environment will obviously be different to what's applicable in an aged care environment when you're assessing the health and safety risks. So from a strict legal point of view, most employers will not be able to mandate having their employees take the COVID-19 vaccination. However, they will in certain circumstances, and one is if there's a specific law requiring an employee to be vaccinated, that employer to require their employees to be vaccinated, i.e. Some of the public health orders in relation to aged care recently in particular, that could be a basis. The second reason is if it's permitted by a lawful term in an enterprise agreement, that's going to be pretty rare, or if it's in their employment contract, which is also going to be pretty rare. So if you don't fall within those two categories, there is a third option for employers. And implicit in the employee-employer relationship is that the employer is able to direct its employees for lawful and reasonable directions. And so the issue is directing your employee to take the vaccine a lawful and reasonable? Well, in most cases, it's not going to be unlawful. So it's going to get over the lawfulness bar. But, it's whether it's reasonable or not. And what this boils down to fundamentally is a work health and safety issue. An employer has an obligation to provide a safe working environment for its employees and for those attending the premises. In those circumstances, that's an assessment of the risk. And as I said before, what's applicable in an office environment is very different to what's applicable in an aged care environment where you have immunocompromised residents who are there. Employers need to take into account, whether there is any reason why someone may not want to be able to take the vaccine. Pregnancy, they've got to, obviously they have, they can't take it because of medical reasons, or they might be religious reasons. But interestingly enough, the work health and safety reason trumps those discriminatory reasons and would prevail where it's appropriate. So the consequences of contravening a lawful and reasonable direction are that it's misconduct, and the employer can move to dismiss. Obviously, there's going to be risks associated with that in terms of unfair dismissal and general protections. If you can mandate the vaccine, then there are requirements to consult under work health and safety laws, and that consultation should take place with your employees. If you can't mandate the vaccines, we recommend having a communication to employees, having them be part of it, and just assessing the risks. I think Michelle was talking about letting people know what the risks are, but personally, I think most employers who can't mandate will assess it by saying, well, we strongly recommend that our employees take the vaccine for their own personal health and safety and the health and safety of their close family. Secondly, many will take it because they've got to travel, so they want to be able to have a holiday at some point. And thirdly, there's business continuity risks associated with it, and that's an assessment that needs to take place. If an environment gets infected with COVID, then obviously if they can't work from home, that's an issue, as opposed to say like a law firm where we can work from home. So that was all I really had to add, Alison and Michelle. Thank you.
Thanks, Carl. Thanks, Alison. Just a quick question. Someone has typed in, does the Commonwealth have a head of power to mandate vaccination generally? So I guess this comes down to these sorts of services are delivered by states, like healthcare, for example. Can the Commonwealth, I mean, even if they want to mandate vaccination, how would they do that? Do they have to pass a law?
No, the Commonwealth already has a law with the Biosecurity Act to mandate certain emergency health powers, but they really can only do that for the safety and protection of the population. Otherwise, it would be ultra-virus. So they could only mandate something that is safe and has the efficacy that it says. And having said that, though, there is a lot of administrative hassle with the current legislation. So they would, in our view, they would have to change the law to some extent to mandate it more generally. But I think politically they said that they won't do that.
Right, okay, thank you. So we might go on to our last speaker, Professor Catherine Bennett. So Catherine is, everyone knows who Catherine Bennett is, but Catherine was trained in epidemiology and population genetics, and she's at, I think, based at Deakin. Is that right, Catherine? And her career cuts across the university government sectors, stints in outbreak detection and response with New South Wales Health and the Australian government. And she's been, a welcome voice during this pandemic on all sorts of epidemiological things. And I hang off every word whenever she's on TV. So really wonderful to have you. Over to you, Catherine.
Thanks, Michelle. And look, thank everyone for their presentation so far. And I just wanted to, I guess, put another lens on this in terms of epidemiology and answer some of those questions that have also started to come through on the chat as well. So first of all, just to say that the common theme coming through is about trusts and partnerships. And I absolutely agree. And I think the other thing that challenges us, though, in the big picture level is that building trust and partnerships is difficult in an imperfect pandemic world. And I just want to take a step back and say that when you're in a pandemic setting, when you have a new agent or a new agent moving into new territory, but particularly with an agent you don't know and you don't understand fully in terms of transmission or health outcomes, short and long term, it is a very difficult world to operate in. And The challenge is that getting information together quickly enough and getting it out to people so we can act on it, and that the population understands it. A key part of risk communication is understanding, what's going on, what the health department knows is happening, what they're doing, what we all need to do. Becomes problematic because not only are there areas where you just don't know, and you do move back to first principles, and for us that includes, the first thing we teach in Epi 101 is, hand hygiene, distancing, all those basic things just to try and stop communicable diseases until you work it out. But also that you go to more general restrictions and lockdowns. So you move to larger enterprise to actually try and stop movement, stop spread until you kind of work out what works and what's needed. But importantly, information also changes your understanding of the situation as it keeps coming in. And I do think that's very difficult because trust and partnerships are built on information exchange. And the very fact that information can change and will change and should change over time as you learn more can sometimes undermine some of that trust. So how you manage those changes to information in some ways is as important as the information itself, and how you get that through your own channels is really critical. At the global level, I think Michelle's covered off on the differences across countries by income status. We do see a relationship, unfortunately, between vaccine access and GDP across countries. It is something bigger, though. Even from an epidemiological point of view, we have to be thinking globally. If we try and solve a problem in our own backyard, and we don't look to all corners of the world where infection is or can happen, then epidemiologically and ethically, we're doing absolutely the wrong thing. Our concern going ahead is not how to manage the variants that have come and gone in a way, the initial variants that we did learn in Australia how to handle to some degree with our contact tracing and so on, are now a thing of the past because they've been replaced by variants that are more efficient. They move more quickly through a community. They have a higher reproductive number. People, on average, infect 6 people now instead of 2 initially. That is a real challenge for us. That's the world we're working in. But we've also got to look ahead to the future. And so in evolutionary terms, we've got to think about how this virus, which we know will produce these mutations that will turn over at a high degree, usually not causing a problem, but every so often causing these variants of concern, that we have to somehow manage that in our big thinking about how we respond to this virus globally. The more replication you have, the more chance there is for mutation that will generate a variant that is equally infectious, if not more, than the current new variants we're worried about, that might cause more serious illness, and of great concern that it might not be covered by the immune response we mount to the current vaccines. So we have a global interest, a shared interest in reducing transmission and infection, because with every infection, you're creating yet more replication chances for these mutations to occur. So that's one thing to think about, that we do have to think at a global level. We have a number of areas where we've looked at, having global commitment to access to vaccines with WHO and a variety of those initiatives. Australia's bought into the COVAX agreement, and that does require countries then to make a commitment to actually supply vaccine or supply funds to support vaccine access to communities. Those things were important to put in place early on. It was an important contribution. They haven't translated the way that we would have hoped to see, and a lot more work needs to be done in that area. And as I said, even if just from an epidemiological point of view, but clearly there's a fundamental moral and ethical argument that underpins all of that as well. There is choice here. In Australia, we don't have that choice yet for all age groups with vaccine, but the choice whether you even have a vaccine or not has to be an informed choice if you're not in a mandated setting. We just talked about that. I think Michelle covered quite well the problems in actually people processing risk, and we see this a lot in public health. It's hard to kind of assess that, but equally so too is benefit hard to assess, and it's something that changes. It changes when we go through a situation like now with the outbreak. So they're the things we have to kind of get better at understanding. For benefit, it's not just direct benefit. It's not just how a vaccine might reduce your chance of particularly symptomatic illness, and even more so, you know, serious illness or death. It's also what that means in terms of our ability to cope with a certain number of infections. If less people are likely to develop serious illness, then that means we protect our hospitals. If hospitals are overloaded, if we do have a high hospitalisation rate, and what we're seeing in the current Delta outbreak in Australia, in New South Wales, is a 1 in 10 hospitalisation rate for cases, with half of those people being over 60, half being under 60, and a quarter of those people ending up in ICU. So if you actually picture that across the country, that's something that impacts health systems. So we're actually not just talking about cases or we're trying to protect against serious illness or deaths from COVID alone. We're also concerned that there can be flow-on effects if your health system's overwhelmed, where you might not be able to provide services to people who need hospital for a whole range of other reasons. So that's what we're trying to protect at a population level. So individually, it does make a difference. You do reduce your chance of catching the virus. We know that even with Delta variant, we're still looking at something like 2/3 the risk of having a symptomatic infection following the virus. If you have one seeding event, currently with Delta, and unprotected people, they will pass the virus on to 6 on average. Each of those will pass it on to 6. So in 2 generations of spread, you can see 36 cases very quickly. We're seeing that in Melbourne now. We're seeing how quickly it's moved from generation to generation. If you have those first people exposed, vaccinated, only 1/3 of them will likely develop an infection. And so you're down to 2. If the people they're exposed to then have less likelihood of being infected, you cut it even further. So your chance of passing it on reduces it as well. And so if you add all those things up, they multiply out. You reduce risk of getting the virus, and then even if you do get a breakthrough infection, of passing it on, and then you also reduce the risk of the next person, even if they're vaccinated or not, actually being exposed to the virus. So that's the kind of indirect effect, which is not only about your good, but also for the good of the population. Some people just say, well, that's not my choice, but ethically, it would be good if we could all think also about what happens at the population level. But even individually, you have a direct and an indirect benefit, because you not only protect yourself if you get an infection, you're also protecting yourself from getting an infection, because you're helping suppress the rate of transmission in the community. Finally, I just want to very quickly say, I think ethical considerations have to be a big part of the conversation about how we move out of the lockdown we're in and the COVID-0 world we live in. This isn't just a political decision, and it's not just a health decision. It is something bigger than that, because we have to work with people in the transition who are at different levels of risk. Initially, because of access to the vaccine, there is, as Michelle said, vaccine intent shifts against the background as well. But we do know that some people, related to their socioeconomic status, culturally and linguistically diverse communities, casual workers, there's a whole range of people that have a number of barriers about access or understanding information or trust, or getting the right information for them from trusted leaders. So we have a lot of work to do, but we've got to manage the transition to a point where, if we've got control of this, if the virus doesn't do it for us first, where we do start to see, you know, the virus in the community. So it's about how we move to that path, and how we take people with us on that path. And that's something I think, you know, we've still yet to have some of those really important conversations. Thank you.
Thanks, Catherine. That was really wonderful. I just want to tease out on the last point. So on having those conversations with these hard to reach, underserved communities, what are your thoughts on that? Because we haven't really done very much of that.
Yeah, I think the government have been working directly with communities as well. So we haven't seen it all through public messaging. I think we've had a lot of criticism of what we've seen of the campaigns to date. I saw a preview of a next round of ad that I think might resonate with more people, which, you know, we absolutely have to do more of that general communication as well. You know, we discovered in Southwest Sydney, an area now impacted by the New South Wales outbreak, that vaccination rates in people above 70 in the community, which are sitting well above 70% generally in the community, were sitting at or below 50% for this particular part of the community. So it really matters, because often communities cluster together and live together and network together. And if you have a group where you have reduced vaccine coverage and they cluster together, then that creates even greater vulnerability because of this direct and indirect effect. Sadly, we have seen one of the biggest shifts in push in the number of people queuing up for vaccines has come with outbreaks. And we've seen that now in Southwest Sydney. And I'm hoping that through, I guess, the understanding of the reality and the impact on community and a community that people identify with, but engagement with the community leaders in both managing the outbreak and then translating that to helping people understand what that risk benefit you know, balance is for them and their community. That's what this will take. And we have to have very nuanced messaging and listen to people and understand what it is they need to know in order to make their own informed decisions.
Fantastic. So we're going to just open up now for general discussion. We do welcome from the audience any questions you might have. There's no such thing as a silly question, so please do ask them, and we will endeavour to answer them. So I might just start with a question here. Is there an ethical dilemma in restricting access of the most effective vaccine, Pfizer, to the population aged over 60? Could this be discrimination based on age? Who wants to have a go at this?
Well, I might just begin as a scientist here.
Yeah.
Just to say that actually, when you're looking at particularly the current variant and you're looking at serious illness and disease, they are neck and neck. In fact, AstraZeneca actually has slightly better results coming out of the UK real world data. We actually went into the vaccine program in order to find a vaccine that would prevent against serious illness and death as the first priority to try and protect health systems. How it relates to transmission or risk of asymptomatic infection is a secondary gain, because that helps us slow down the mutant versions, the variants of concern. So in fact, when it comes to the individual, what the most important thing is preventing against serious illness and disease. That's the benefit. And if we have a very rare risk and we associate that very rare risk with different age groups, then I do think, you know, I had AstraZeneca. I was in a group that was, you know, that later flipped. But at the same time, at the end of the day, I thought if that frees up a dose of Pfizer for someone who has a marginally higher, very, very low risk, then I would still be happy to do that. And my risk of disease itself was going to be was higher than someone in their 20s.
Carl, there's a sense of ageism that has crept into the community, particularly amongst the boomer generation over this. It has come through loud and clear. So what do you want to comment on age discrimination? How you would counter that?
Well, yeah, well, from my perspective, it seems to be a form of indirect discrimination. We've set up a rule which applies to two different parts of the community differently. And it all boils down to whether that rule is reasonable. And now I'm not a doctor, but that's what the evidence would be. The rule that you're giving the vaccine to people aged over 60 first, or that you're preferring them to those under 60, is that reasonable based on the medical evidence? And I think that chart you showed before, showing the associated risks for different age groups, probably would be Exhibit A if you were defending a case of indirect discrimination, saying it is reasonable. So that's what I've got to say.
Interesting. On the topic of, I was going to say aged care specifically, can we just revert back to that, because this is a pretty big deal. We've got issues with availability. We've been told that this cohort must be vaccinated by mid-September. Is there going to be a risk of some workers feeling pressured to take one vaccine over another, or do you think that that's not likely to happen? Has there been, and I don't know if there's been an announcement that all aged care workers will be given the Pfizer dose for a vaccine, for example, but I'm just not clear on that.
The government has announced measures to assist aged care workers to access the vaccine. So the government's already on top of that issue. And
what are they going to get at? I mean, are they going to have a choice then of choosing between AstraZeneca or Pfizer, or are they, what if they don't want to take the AstraZeneca vaccine?
I think that's something that's still under discussion between the industry and the government.
So 90% of aged care, I read this the other day, 90% of aged care workers are female and about a third of them are in childbearing age. What are your thoughts, Alison and Carl, on whether some of these workers may not want to have a vaccine? They may be pregnant, they may not want to disclose their pregnancy, they wouldn't want to be discriminated against. Now, the Pfizer vaccine is recommended for pregnant women at any gestational age, and it's been shown to be safe and effective, but understandably there'll be some women who are pregnant who may not want to have the vaccine. So how would you navigate through that?
From my point of view, the government, I think we use what the government's been doing with the flu vac in aged care. There's been some exceptions. They're only required to have it if it's reasonably available, and they've taken the view that if someone's allergic to it or can't have it, then it's not reasonably available. And I would expect that the government would take the same view in relation to pregnant women. Carl?
Yeah, I mean, that's a real live issue, and it's one that I was raised with me today, actually. Someone who is pregnant, doesn't want it, but is in aged care and would be required to go to facilities. And now they don't want to go to the facilities because they don't want to take the vaccine, so they want to stay in the office. I mean, it boils down to whether it's reasonable in the circumstances, I think. And that's a weighing of the risks. The risk of, well, what is the issue with being pregnant and taking the vaccine? There'd be medical evidence on that. And then the employer's right to mandate. And if the employer's backed up by a public health order, then the work health and safety obligations often trump discrimination laws. There's exemptions to discrimination laws inbuilt that say that if the employer is doing something because of work health and safety, then discrimination laws, don't apply.
I'd like to also add, we've talked in our presentations due to the limited time about employment laws and discrimination laws, but don't forget about our duty of care to the vulnerable. So that's something that we need to really take into consideration. We might employers might decide to take a risk on being prosecuted for unfair dismissal. However, they're keeping their residents and clients safe. And ultimately that might be what they have to consider as the ultimate obligation.
Yeah, and they've also got the ability to redeploy. It's not a real ability in all circumstances, but it's an option for an employer. So as we've discussed today, it's a matter of having a conversation, being transparent and trying to have some trust and then looking at your options.
On the issue of trust, I just want to go back to this issue of, information sharing in the era of social media and, reaching and the evidence changes so quickly. There's been some interesting models used in other countries. For example, the US has really taken on outreach, using its most senior advisors, the head of the CDC, Anthony Fauci, head of equity and diversity, etc., their Surgeon General, and they have these, public forums on a regular basis where they answer questions, Q&A style. This has been happening throughout the pandemic, and they've done more than that as well. They've been now going into communities with a lot of, TV cameras and really getting a lot of publicity. There's been not really that much of that here in Australia. And I just wanted to get your views. I might start with you, Bill, on how we should, what are your thoughts on that?
Look, one of the problems in Australia is there's been far too much concentration on what you call top-down information by older people, by politicians and scientists and so on, all of whom, like me, grew up in an era where people read newspapers and they watched free-to-air television and they sent emails. Now, that's not how the majority of Australian people get their information. So if you're not on TikTok, much less Facebook, but on the methods of communication that young people use today, and if you're not working with and through the massively diverse number of communities, English, culturally and linguistically diverse communities and remote communities and so on, if you're not there, not just telling them what to say, but working with them to craft the messages, then you're not making the impact that you should. I think back in the HIV days, we knew what the messages were, right? They were very simple, but we, the governments of the day, created structures to reach out to the most at-risk communities and gave them the responsibilities for conveying those messages and the behavioural changes that flowed from them in a way that made sense. And that's what made them change behaviour, or brought about the behaviour change and cemented it in place. Now, there's been not enough of that in Australia. And I think whatever's going to now come behind the vaccination campaigns, and as COVID changes and the problems become more complex, then we need to build that community up consultation and do a lot less of this top down.
I agree with that. I don't know if Catherine wants to add anything here, but I've found that people are hungry for information. They want depth sometimes. Others don't, but and often it's just not enough to read the ATAGI statement. I've given a lot of lectures to GPs because they're desperate for information as well. And the information changes; it's moving so quickly. So the medical profession tends to look after itself. We give lectures to each other and we communicate, but where there's a major gap with the community in passing that information through a credible voice. Catherine, what are your thoughts?
Yeah, absolutely. I think one of the things we've seen is, because we have had this challenge to supply of both vaccines, actually, at the start, there was a sense of, we don't want to advertise if we can't meet the demand, or we're going to have advertising campaigns that match the phase we're in. And the first phases were more associated with your place of residence or work, if you're in phase 1A or 1B, that meant the emphasis wasn't so much on selling the vaccine. It was actually, explaining how people had access, and it was sort of a clearer risk and benefit for people on the front line, for example. But I think that's a mistake, because it creates a void, and you've got people who are thinking ahead to when they will be eligible, and they're hearing all this other stuff everywhere. And I do think it's a challenge. We know from the start there's probably been a greater pandemic of misinformation and disinformation, as people call it, that's been running in parallel. And there are different forms of censorship. I've had this conversation, I'm on LinkedIn, I have a lot of people who come to that place just to get some data without it being political or anything else, just being as it is, data, and an interpretation of what, where we're at in terms of managing local outbreaks or things more globally. But in fact, we often attract people then who just come in and they have a very set, often cut and paste kind of series of questions, or wrong thinking about things, misinterpretation of data. Often old data is constantly being reported. And I make a point of trying to not to block people and to respond to them, because that takes my response back to their page, and you hope that at least it gives other people access. But it's incredibly hard work, and invariably you get to a point, not invariably, but in some cases you get to a point where you do have to block them, because they are in effect censoring you by downloading all this stuff en masse every time you try and say something. So I think it's a time where some early work on modelling around pandemic misinformation showed that, in fact, it doesn't take a lot of credible, good, consistent information out there to put the other stuff aside, but you have to work really hard to get that information into those right channels at the right time, or else the job gets harder.
I think that's true. It's called flooding the zone. I learned this the other day, that, that people will jump onto your social media channel and then you'll get inundated. And there's a strategy behind that, an entire network. I would say, Bill, go ahead.
I just really want to reinforce that point Catherine made about the vacuum. Now, there are reasons we know about procurement and supply that's been a problem, and they didn't want to go out and advertise because they didn't want to drive people to vaccination. But that was a very good opportunity, in my view, to get out there and talk about some really basic concepts. There'd be a chunk of people in Australia who would not be able to tell you the difference between vaccination, immunisation, inoculation. These are very long words and they all mean something different. But let's remember, a lot of people don't have the scientific education and background. So this debate is being conducted in terms of words that we understand and are tossed around. But really what we're asking people to do can be very confusing. Some people think that if you're injected with a vaccination, you're being injected with COVID. And they worry about that. And they worry that the needles are going to hurt. And really at this basic level, we've got to have the wit to educate people who may not be as scientifically literate or ever had to worry about these things and who are justifiably apprehensive and concerned. So by all means, wait till we've got the supply to advertise where to go and get it. But there's a lot of other basic work that really ought to be being done now.
Absolutely.
And if I can, sorry, Michelle, just
I was just going to say,
points.
The concept of health literacy, everyone, that it's very patchy across society. But go ahead, Catherine.
No, and I think just great points that Bill's raised as well. That one of the things I learned very early in my career is you don't know what people know. If you go and ask them, do you know what vaccination is? They'll say yes. Actually, whether they really know or not, you don't find out unless you have a conversation. And I do think that's something that, it's hard to do in surveys. There's lots of things people have been doing, not just the government departments directly, but a lot of others working in the public health space, trying to understand people's thinking. But it's often the temptation is to kind of, rather than getting them to provide their understanding of something. And that's actually what you need, because then if they've got some wrong thinking in there that's come from other channels, that you then can put on the table and have a conversation with them and help them understand that it is different, that it's not a real virus that's being injected into them and so on. But you often don't know if you don't ask the right questions. And so we do have good people working in this space. But that's the most important thing, that we actually understand what people think they know versus what they know, given the amount of misinformation that's out there, and sometimes just confusion. It doesn't have to be malicious that the people have been given the wrong information. Sometimes it's people trying to find things out for themselves, draw the wrong conclusion, looking at data out there, not understanding all data is complex. Health data is complex. You can't just look at it at face value. And unfortunately, some of that's happened and people have now got the wrong end of the stick, and it's harder to get information to them because they're no longer asking the question. They think they know the answer.
I agree. I just wanted to draw your attention, I guess this is for Alison and Carl. There's a question here from Kerry, and it touches really on the no-fault compensation scheme that Australia does not have. So, for example, if you take a vaccine and some harm comes to you, what is your recourse? So doctors are protected. We have an indemnity scheme now set up to protect us from being sued, for example. But what about patients? Can you clarify what the situation is there?
So in Australia, we don't have a no-fault compensation scheme in relation to vaccines generally. There's one in New Zealand, for example. But what we do have is civil liability law. So if someone is negligent, there's a right to make a claim. And as to whether someone suffers an injury, it really depends on the circumstances as to who is responsible. So for example, if there is an issue with the manufacture of the vaccine and there's a product liability issue, there could be a liability for the manufacturer, although we know that there are agreements between the various companies such as Pfizer and the Australian government where certain indemnities have been provided, and that's freed up the ability to supply to Australia. So it's not that people don't have any recourse. It's just that the laws in Australia that have worked effectively continue to work in that case. The more interesting question, though, is the issue of informed consent or consent with being provided appropriate information, and whether the population are being pressured into consenting to a known risk of a vaccine. And this is a great forum to discuss that, because that is essentially an ethical issue as well as a legal issue. So we'll see as to what will happen in the courts at some point, but essentially for a legal point of view, from consent, it has to be freely given. So if there's someone who has been forced to give consent, that's not valid consent, and there could be a claim in that case.
So my understanding then from that is that if harm came to a patient, the burden would be on the patient and their family to then take this forward through the courts.
Can I just clarify that actually, if we haven't had it formally announced yet, they have alluded to it. There is actually going to be an injury compensation scheme. I'm not sure if it applies to state-run facilities or it's from the government working with the GPs, part of the Commonwealth rollout. But the idea was to have a pathway for people with serious injury that would mean they didn't have to go through the legal process. It wouldn't require lawyers to actually make a claim. So it's probably not as comprehensive as some of the others, but that has been reported to us as something that, along with the GP indemnity, which was a discussion about AstraZeneca, that was also part of that. So it would be directly available to the patients.
Yeah, but the details of that haven't been announced yet. So.
That's right, but that's
the devil's in the detail.
Always.
Catherine, is that state-based or national?
That is Commonwealth. So yeah, and that's perhaps another question about whether it covers state hubs that might also be offering AstraZeneca. I don't know.
Another question: as a principle, do penalties for non-vaccination work? If so, what would those penalties look like? Penalties for non-vaccination, and what would they look like?
So currently what we're seeing is that we've seen orders that are made under the public health legislation of each state and territory, and that includes the orders for the flu vac for aged care workers, and other orders that are made in relation to masks, and the orders in relation to staying at home, etc. So there would be currently similar penalties that we've been seeing for the breaches of that legislation.
I wanted to just ask Bill what he thought of the announcement about mandatory vaccination of aged care workers. Now, I'm not necessarily against it, but I just felt it was a little bit heavy-handed. And my understanding at the time was that aged care workers actually were very keen to get vaccinated. They just had problems with supply and access to their vaccines, and other kinds of barriers. For example, being casual workers, they get vaccinated, they might need a day off work, but they lose work in doing so. Do you think there was a little bit of politicking going on there with that announcement, Bill?
Yeah, look, this talk, in any case like this, you've just got to talk and talk and talk and talk, and take the time and trouble to go to the workers, to the unions, to the aged care employers, and really put the effort into understanding what is needed to persuade most aged care workers to be vaccinated, or people in healthcare settings. I mean, states and territories do insist on that in other places and settings and times. But what I think is very disruptive and wrong is to come down with an ex cathedra pronouncement in a press release and then have to walk it back because there are consequences, at least just in availability of employment. Do you have enough people if a chunk of people walked out of the aged care setting? So all of these things are perfectly foreseeable and predictable if you sit down and talk with the people who are closest to the problem. That it's time consuming, it can be difficult, but it will eventually come up with a much stronger and more sustainable solution than just handing out a press release and saying, live with it.
Absolutely.
I agree. I think the most damage we've seen up to date is where there's been inconsistency of messaging between the government and the peak medical bodies. I think they really should have that conversation first before they're announced.
I saw something interesting, just going back to this theme of the underserved communities. I don't think we should underestimate this, because these communities are going to be the ones that will be hardest to reach, and they will be, effectively the last mile to bring to vaccination. So it was interesting this morning. I was watching the ABC feed, and I think it was a mayor maybe of Fairfield or a councillor was talking about, the divide in Sydney between, Bondi suburb, eastern suburbs, and what's going on in Fairfield, where they have mounted police, dog squads, and the air wing. And he said it's just two Sydneys. What are your thoughts on what's going on with the way this has been handled, and what an impact do you think it's going to have on the community? Bill first, and then Catherine.
We can't afford any more what I call balkanisation of this response in Greater Sydney. In the last few days, we've seen the most extraordinary propositions from some of the members of parliament around the place saying, well, put a ring of steel around the northern beaches or Wollongong, and we're right. I mean, it conveys that it's just ludicrous. The virus has no idea about Sydney local government areas. And any idea that you could separate out by postcode or local government areas the good bits and the bad bits is just preposterous. I mean, it falls, as any scientist or doctor knows, at the first hurdle. Nevertheless, that is getting out there. And of course, people in areas where there is at the moment no record of the virus are very eager to say, well, it didn't come from us, it came from the suburb over there, or the east or the west or the north or the rest of it. I mean, this is, it would be laughable if it were not so serious. So there's got to be a way in which people understand in Sydney that truly we're all in it together, that the virus doesn't care where it goes. It will go where government decisions and weaknesses exist that allow it to replicate and to move. And there's got to be a lot of talking that welds together the Sydney response rather than allows it to fracture any further. If this goes on much longer in Sydney, I really do worry about what you call the social cohesion that is imperative if this thing is to be put back and removed as a threat until we're all much more vaccinated.
Wise words. Catherine, what are your thoughts? It sounds like these communities are, this fear of stigmatization if it hasn't already, landed.
Yeah, it's a really serious problem. Completely agree with Bill. And we saw it in the second wave in Victoria, the very part of the community where most of the casual workers who were the hotel workers who were infected at work and brought the virus home took it to a similar belt in Melbourne, where we had a high number of people who were from migrant populations, people lived in larger households, lots of casual workers. It spread really efficiently. It moved into the aged care homes in their own communities, and that's where we suffered the greatest losses. And yet it was often couched, and I remember our own Chief Health Officer would refer to those suburbs as the usual suspects. And they didn't start it, it impacted them, and they had the biggest job to do to pull down local transmission, just as Southwest Sydney now does, because it's embedded in the community. And people don't know they've been exposed. They don't know that that person that they met, that they had a quick chat to in a local grocery store was a case, or that they were somehow linked to a known exposure site. So it's really hard to get people on board if in fact they can't know now that they're connected to the outbreak unless they're all testing absolutely everyone. So it is about bringing a community together, working with them and watching everything right through to the language we use to describe those areas. And I think it was worse in Victoria. I think it actually helped stimulate the recognition that we needed to have local public health units. So you had public health services embedded in community and building relationships with leaders over time, because that's how you need to respond, rather than have a top-down approach that's trying to manage a whole city and manage disgruntled people who think we don't have cases and we don't deserve this, and somehow those other people do, and that you can put a ring of steel around them.
Fantastic. Now we are on the hour here. So we've had a fantastic discussion. I want to thank all the speakers. I mean, we could have gone another hour, I think, with the issues that have been raised. But what has come out loud and clear is that transparency builds trust. Evidence-based communication is essential and it must be kept up to date because this is a moving feast. We need far more outreach and working with communities. And at the heart and soul of this pandemic response must be the people. We must take the people with us, all people, whether you're in a blue or in a suburb or a red suburb or whatever suburb, we have to take them all with us in order to combat this pandemic and really, achieve its success, which is vaccination, which is what we all want and crave. I find it extraordinary that government still does not understand the importance of community and stakeholder engagement. It is public policy 101. So let's hope this message gets through. And I would like to thank everyone for participating and for the audience for sharing your questions. Thank you.
Thank you.
Could I just on behalf of the Australian Ethical Health Alliance, really extend deep gratitude and thanks for an outstanding debate and dialogue and discussion of the highest quality from a caring and professional subject matter experts. You've done a great service to the community. Clearly your ethical principles are reverberating right around the country. I would like to say that for those of you who may not be aware, the consensus framework for ethical collaboration in Australia is actually the largest of its type anywhere in the world. And Bill made a great comment, I thought, earlier on, talking about how ethics and morality underpin decision-making. Australia is actually seen as a leader in this space. And I think what we saw here today was the platform, a good platform for collaboration and interaction. Promoting this group, this exchange assisted promote public confidence and trust and encouraging better dialogue, trust and respect. And I think it really highlights the importance of having conversations like this through a symposium like this. So on behalf of the 75 member organisations, on behalf of the 14 member steering committee, can I thank each and every one of you. Thank you, Michelle, for moderating. Thank you, Bill, for your insights. Thank you, Alison and Carl, for your guidance on the legal side, and Catherine for educating us more about science. And I would also deeply like to express our thanks to Talissa Trevelyan, who provided a lot of the backbone to get us all organised for this symposium. So on that note, thank you very much, everybody, and have a great afternoon.